Thank you, Moritz, for this introduction, and welcome everybody for this last talk of the session, or actually the day. I would also like to thank one of the co-authors, it's Christiane Leibold. She did all the work gathering the data for this follow-up study. There are quite a few studies out there evaluating mid and long-term follow-up following pelvic osteotomies for the treatment of dysplasia. And this graph tries to summarize them. On the x-axis you have the follow-up, and then on the y the survival rate with total hip arthroplasty as the endpoint. There are different colors, and the blue ones are the ones for PAO, and you see how steadily the survivorship decreases over time. There are a few over 15 years, and the one with the longest follow-up is the one at the right-hand side at the bottom from Till Lerch. And he evaluated the outcome at 30 years and found a survivorship of 30 years. But he included in this study other endpoints, such as the conversion to total hip arthroplasty, also progression of osteoarthritis and hip function. And this series includes the very first PAOs ever performed. So it's a quite special series. It's also heterogeneous regarding the indication, the amount of previous surgery, and osteoarthritis. And therefore, we wanted to have more universal results for the PAO, and the aim of this study was to calculate long-term survival and predictive factors, evaluating all the PAOs that have ever been performed at this institution since the first case in 1984 in adults and adolescents. It's a retrospective case series. It comprises somewhat more than 1,000 PAOs in 872 patients. About 20% had bilateral surgery, included the patients and surgeries from 1984 to November 2018. We had to exclude 69 patients because we did not have a one-year follow-up, and this resulted in a follow-up rate of 93%. Because there were so many patients, we had to choose a very simple and single endpoint, so we only took the conversion to total hip arthroplasty. We have no results about hip function or follow-up radiographic results. We just contacted the patients whether they have received total hip arthroplasty and when it was performed. Then we calculated survival rate using the Kaplan-Meier analysis, predictive factors with the corresponding hazard ratios. There are two indications for the PAO. One is the classic indication on the left side for hip dysplasia, and the other one is acetabular retroversion. You have been heard before about this indication. So for hip dysplasia, it has been performed since the first day in 1984, and for acetabular retroversion, we started using it from the late 90s when the entire impingement concept was introduced, and the PAO was used to reorientate the acetabulum in the optimal position. There are 703 patients in the dysplasia group and 105 patients with 129 PAOs in the retroversion group. They differ regarding the age. They're somewhat younger in the retroversion group, but in both groups, the majority are female patients. There's quite a difference regarding the amount of previous surgery. It's 30% in the group with hip dysplasia and 14% in the group with acetabular retroversion. But in both groups, the majority is due to intertrochanteric or previous pelvic osteotomies. Quite interesting is that PAOs have been performed in almost 10% to correct acetabular retroversion, which was actually due to previous pelvic osteotomy and iatrogenic acetabular retroversion. Follow-up was 14 years in the dysplasia group, mean follow-up up to 35 years and 12 years in the acetabular retroversion group, also with a maximum of 22 years. Here are the results. Now for the PAO for dysplasia, there were 205 hips that converted to total hip arthroplasty out of the total of 844. This results in 24%. And due to the different or the wide range of the follow-up, the Kaplan-Meier results in a survivorship rate of about 50% at 30-year follow-up. Of course, there are predictive factors. We evaluated them. We found age to be predictive. That's nothing new. We have found that in previous studies, and many other authors have found age to be predictive. It's about 75% survivorship rate in the very young patient, younger than 20 years, and the curve drops to less than 20% survival for those aged over 40. Even more predictive is the preoperative joint degeneration. We used a simple staging system of Tönnies, and you see also very high survival for those without any signs of joint degeneration on the conventional image. It results in 75% at the 30-year follow-up, and the curves drops rapidly in Tönnies stage 2 and 3 with almost none hips surviving 30 years. This is a good example from the historic series from the 80s, a young female patient, a nice joint space with no signs of joint degeneration. We could follow up her at 10 years, even at 20 years, and she came back after 30 years, and it's a well-preserved joint without any signs of degeneration. We found some difference between hips that had previous surgery compared to the ones that had no previous surgery, and found about 10% better survivor in those without previous surgery. And then we compared a series of patients with today's indications from the late 90s till today, and compared it to the historic indications from the 80s, where there was less emphasis in putting the acetabular in the right or optimal orientation, and certainly no impingement correction, and we found a better survival of about 15% at the 20-year follow-up. Interestingly, we found no difference regarding the type of dysplasia. We compared concentric and dysplastic joints with those that had a subluxation or even a false acetabulum, and although the curves look like there was any difference at the 30-year follow-up, there was no significant difference regarding subluxation or dislocation of the joint. They all do well. Here, the predictive factors with the corresponding hazard ratios, the same predictive factors you have seen with the Kaplan-Meier analysis, and the one with the most pronounced hazard ratio is the preoperative osteoarthritis. As I've mentioned before, there's another indication, acetabular retroversion, or severe acetabular retroversion can be used to reorientate the acetabulum. We follow up those patients too. They showed a survivorship rate of 93% at 22-year follow-up, which corresponds to about 5 conversion to total hip arthroplasty in the total from 129 hips. We again found some predictive factors, but what you have to take into account there are only 5 endpoints out of 129 hips. Still, it's significant, again, the Tönnies classification and the ones with previous surgery, but you see there are in total only 5 steps, 1 step in the blue curve, and all the others have been found in those with previous surgery. Age wasn't predictive, all the other like BMI and gender was not predictive. In conclusion, these long-term follow-up confirms predictive factors that has been found before. Actually, age at surgery and osteoarthritis are the strongest predictive factors. The current indication for PAO with the goal to create impingement-free range of motion seems to result in a better survival at the long term. However, so far, detailed radiographic results from the current series are missing. We have to evaluate the radiographs to see whether those hips with optimal reorientation and the good offset result in better long-term results or not. Of course, this takes a lot of work to evaluate all these X-rays, and acetabular retroversion seems to be a pathology which results in a very high survivorship at the long-term follow-up after PAO. Thank you for your attention.